everybody for being connected to this and welcome back after the break of summertime to this young conference series, which has the main objective of supporting young early careers investigators development and to encourage, particularly now in COVID time, the interactions among the COST members so that we can be in touch and share our, hello Guru, you will be presenting next Nottingham meeting at the end of the session.
All right, why not?
Very great that you joined. Thank you, Guru. So I will give the word to Anna Licata, who has been the mentor of Goran during the short-term scientific mission that he did at Palermo University. Thank you, Anna.
Thank you, Maribel, for your introduction. And our speaker of today, it will be Goran Bokan, Doctor of Medicine. He is still resident of internal medicine, and he for 3 years working in the gastroenterology and hepatology. He started working in hepatotoxicity from last year, and for me it was a great pleasure to start with him, to introduce him in this very interesting and relevant clinical field. And he is a member of the COST Action CA 17112. It is a master substitute for the Bosnia and Herzegovina, and he working at the University of Banja Luka. For the last 15 months, he worked at COVID hospital, and now he attendees to the endoscopy and interventional gastroenterology procedure. During the short-term scientific mission in last 2 years ago, 2 years ago, because we want to forget the year of COVID. Goran was a very nice guy. He worked with all people with whole residency, and worked in the US lab, and also with Professor Soresi. He got some examination of color Doppler of the portal vein thrombosis, people with cirrhosis, with viral cirrhosis. And also he went to the gastroenterology unit to learn how measure liver stiffness by FibroScan. So he worked in the outpatients, and then he did the ultrasound examination and FibroScan examination of the people who previously he have seen, and he had the interview by clinically. So now I don't want to leave more time, and I want to get words and to Goran. Please, Goran.
Good afternoon. First, I would say to Professor Licata, thank you for nice introduction. My current topic today is about the future perspectives in dilinization, with the accent on how to save the liver. So first, if you want to say in only 3 sentences, what is the liver? I'm zipped that in this way. The liver is multifunctional, ultra super powerful machinery, which is captured between the paradise and hell of human habits, and real fighter with everyday toxin overexposures. Because of the last or third sentences, that's the reason to focus the main problems in clinicians in the field of gastroenterology who have every day in their practice. That the problem is liver damage, and on this slide we can see the most common causes of acute and chronic liver disease. In this table, this is the list of most common agents such as viral, autoimmune, inherited metabolic liver disease, alcoholic liver disease, non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis, hepatic vascular disease, and biliary disease. Because of our society named DILI and cost action, the most focus will be placed on DILI or drug-induced liver injury. So this presentation I divide into 5 parts. In first part, I'm going to talk something about DILI and HEALI. On another part, second part, I'm going to talk about short-term scientific mission in Palermo. After that, I will present 2 cases from my clinical practice. One is about DILI and one is about HEALI. After that, talk about future collaboration and how I got an idea to title this presentation Future Perspectives in Dilli-nisation. What does it mean, Dilli-nisation? And at the end, I would like to call younger PhD students and colleagues to come to Banja Luka to obtain practice short-term scientific mission like I did in Palermo. On right part of this slide, you can see the list of drugs and classes associated with DILI and type of liver injury. First, all we know that the DILI is a broad concept that also includes not only drugs, liver damage, that include food-induced liver injury, as well as dietary supplements and other nutrition. So, when DILI occurs in a human organism, in liver, it could be one of 2 known types. First one is idiosyncratic DILI type. That's those independent type, which occurs few weeks or few months after the, for example, antibiotics therapy, 4 weeks after therapy of amoxicillin with clavulanic acid, or few months after nitrofurantoin therapy. And idiosyncratic DILI types could be also classified as a metabolic and immunologic type. Other type of DILI is intrinsic DILI, also called dose-dependent DILI type, and that occurs, for example, after taking paracetamol in therapeutic purpose in higher doses than it's suggested. So that's the predictable reaction, and the main differences between both of types of DILI is that in intrinsic DILI type, when you analyze the histology of the cell, that's the absence of signs of inflammation. We can see, for example, necrosis of the hepatocytes or apoptosis, but without any signs of inflammation. That's the difference, because in idiosyncratic DILI type, we also can see signs of inflammation, because in dead zones of hepatic tissue after the exposures to antibiotics, it can cause the liver damage, because after the liver tissue and leukocytes produce the chemotoxic factors that also activate macrophages, leukocytes, and produce interleukin, which can lead to progressions, for example, steatosis, to fibrosis, and later to cirrhosis. When we talk about DILI or drug-induced liver injury, we also think that's very important to always talk about herbal-induced liver injury, because in everyday practice, we can see that some kinds, but not often. On this slide, there is a list of products and which toxin substance from these products can cause different type of damage in the liver tissue. So I first want to say you, before I obtained my clinical practice or short-time scientific mission, I didn't think a lot about DILI in the patients with elevation of liver enzymes, because we didn't learn a lot about that on faculty. And first association with elevated liver enzymes, the hepatocellular or cholestatic enzyme is, for example, viral lesion, cholestasis because of biliary stones, autoimmune disease. But after a short time scientific mission, I everyday clinical practice think as put more accent on DILI as a diagnosis of the current patient problem. So if you have a patient with elevated liver enzyme, first we should do is to take anamnesis about past disease, current disease, and also past and current therapy. After that, when we perform the laboratory parameters, what's the most important for us is when we think that the patient has a liver lesion, to make a differentiation is that cause or that's hepatocellular, cholestatic, or mixed type of lesion. If the ratio between ALT and alkaline phosphatase is more than 5, it's suspected to hepatic cause or hepatocellular type of DILI. If the ratio is less than 2, that's suspected cholestatic disease. Mixed type of injury is if the ratio is between 2 and 5. After performing the laboratory parameters, the next step is to do the serology test on hepatotropic virus, such as ABC, hepatitis virus, or other viruses such as Epstein-Barr, cytomegalovirus, and others. Also, we should analyze the status of antibodies and autoantibodies in the blood. And then if it's not enough to confirming the diagnosis, also is very important to perform imaging diagnostics procedures, ultrasound, CT, MRI, fibroscan, or MRCP, and other tests. And at the end, final considered the diagnosis is to perform liver biopsy. But now we have a more sophisticated procedures, so we can conclude that the liver biopsy is not always necessary to perform to every patient to say that he or she has a DILI. The diagnosis of DILI, of course, is based on principles of exclusion. So that's the main thing. Thanks to Russell criterion, it's easier to confirm the diagnosis of DILI. So in this table, we can see parameters which we measure and analyze in patients suspected with DILI. So the final score, when we calculate that, it could be in range from -3 to +14. So the stratification of the Russell score, it could be say that the patient is probable, highly probable, possible, less possible, or excluded the liver lesion. In every lesion, the main start is the simple steatosis or non-alcoholic in alcoholic and non-alcoholic fatty liver disease is steatosis. In this part, in the second column, we can see that in steatosis, the main process is accumulation of fatty droplets to the hepatocytes, which cause the moving nucleus to the peripheral part of the hepatocyte. And also it could happen, and it's associated with metabolic syndrome, which include diabetes type 2, the dyslipidemia, of course, obesity, and other conditions. So fat droplets are foreign body for our immunity and then cause the activation of macrophage and migration, firstly migration of leukocytes who produce inflammatory cytokines that cause the inflammation at the level of hepatocytes. In other steps, if the it's non-alcoholic steatohepatitis. If that process continue, it could in the future pass to fibrosis and liver fibrosis because in the next step the hepatocytes are infiltrated with scar tissue. So the process of steatosis and non-alcoholic steatohepatitis in some parts are reversible, though fibrosis and liver cirrhosis are in irreversible process. At the end, we have in some patients hepatocellular carcinoma, but it's not almost associated with DILI. That's only step-by-step liver lesion I would like to present here. So, in summarize, when we talk about liver lesion and how to save the liver, it's very important to say that everyone first should suggest to correct their lifestyle and nutritional habits. Also, to take to GPs and to patients to careful use medicaments and herbals. In a situation, for example, with stomach problems, wherever you can make a substitution that use prokinetics in substitution for PPI is better option, especially, for example, in patients with liver cirrhosis, ascites, decompensated liver cirrhosis with ascites and other complications. PPIs reduce the acidity of the stomach and also cause the changes in intestinal microbiota, which can, in 1% of cases, cause the spontaneous bacterial peritonitis. Also, because it's known that statins could cause the liver lesion, cause hepatotoxicity and liver injury. In case we can use that, for example, ezetimibe, inhibitor of enteral cholesterol absorption, that's absolutely suggested. And to use the drugs that bypass the liver metabolism, to use the wide spectrum medicaments, not only metabolized by cytochrome, then in other ways to metabolize, for example, flammine monooxygenase system and others. And always think about impacts of probiotics, especially in patients with non-alcoholic fatty liver disease and with components of metabolic syndrome and other manifestation of gastrointestinal disease, IBD or something like that. So on second part, it's important to say that 2 years ago, I have been in Palermo and obtained a clinical practice under the mentorship of Professor Licata. And the purpose of this training was to perform and to learn how to perform the sonography examination of abdomen, as well as color Doppler of portal vein and hepatic veins, and after that to perform the liver stiffness measurements by fibroscan. It's interesting to say that the majority of patients were affected by viral hepatitis or cirrhosis in Palermo, while in my hospital, for example, the most patients with liver cirrhosis, that liver damage was caused by alcohol chronic intake. The remaining patients had a non-alcoholic fatty liver disease and MASH. The patient I saw in Palermo during my clinical practice. And also during that training, I had a great pleasure to attend to the meeting of second working group of cost of action in Palermo, which been organized by Professor Licata. So that was the decision that I, after that, really want to be part of this society, this network, and to improve my past knowledge, wide spectrum, and always think about DILI in case that I see patients with elevated liver enzymes and also with liver injury. This is one funny picture from Palermo. Last picture, last day, when I told Professor Licata, we took few pictures normal, and after that told the professor, now I want to take one funny pictures for memory. And in third part of this presentation, I will present the two cases from my clinical practice. First one is about DILI, second one is about HILI. First case is about flutamide, liver injury. Flutamide, as we know, is a non-steroidal oral anti-androgen, which used in therapy of prostate cancer. Also, it could be used because of hormone imbalance in women and men, but because of hepatotoxicity, you can see on this slide the incidence of hepatotoxicity associated with idiosyncratic type of liver damage. So next final conclusion is that use of flutamide in therapy in outside of malignant disease is not recommended. Later we will see on slide the reason for that. From my clinical practice, the case is about 52-year-old woman who went to endocrinologist because of polycystic ovarian syndrome and hormone imbalance. The doctor prescribed the flutamide with this schema to patient, and after 2 months renewed therapy for another 2 months. Unfortunately, he didn't perform any hematological test for that 2 months, so the patient suffered from liver injury. Patient didn't have any other comorbidities, didn't use alcohol and other drugs and medicaments. 3 months, nearly about 3 months after the started flutamide therapy, the patient presented with many symptoms, which the most important are nausea, vomiting, dark urine, pale stool, pruritus, and jaundice also. On this slide, I will show you the pathological signs of laboratory parameters after performing the laboratory. We can see that on this slide is suggested that patient had a dominant hepatocellular type of injury. Also, when you calculate the ratio between ALT, alkaline phosphatide, that's the mixed type of liver injury, but the ALT and AST are more elevated than cholestatic enzymes. During the diagnostic protocol, which we saw on second slide, other potential etiology was excluded: viral, autoimmune, vascular, metabolic, and every other. So the patient suggested to withdraw flutamide therapy, and 6 weeks after that happened the normalization of aminotransferase levels. 6 months later, when we perform elastography just to check the status of the liver parenchyma, we can say that the patient has a 3rd grade of steatosis and 1 grade of fibrosis. On this slide, in this table, this table, we can see cases reported in study and authors from clinical practice about hepatotoxicity of flutamide in female patients. It's the review of literature. Here's a list of patients, type of liver injury, and final outcome. So because of lots of adverse reaction after flutamide usement in therapy, the final conclusion is that use outside of therapy of malignant disease is not recommended in clinical practice. Another case is from my department, hepatology, from this year, a few months ago, about ashwagandha liver injury. Ashwagandha is a substance that not only patients, just people use because of its neuroprotective and anti-inflammatory activities, also used to increase energy and to reduce the fatigue. We can say that ashwagandha is generally safe for use, but in some cases it can cause liver injury, especially cholestatic or mixed pattern of injury, and some other signs and clinical manifestation of liver injury. Because why it happened, it's not clearly known yet. So my patient had a 30-year and took ashwagandha in capsules, 450 milligrams 3 times daily during the 6 months until April this year. And one day the patient had a problem and go to GP because from the morning he has vomiting, itchy skin without rash, darker color of urine, and lighter stool. Also, last 1 week before the symptom starts, he noted that lost about 4 kilograms. Patient didn't have any comorbidities, also don't use alcohol, and don't use any other drugs. When we performing the liver test, we can see the elevated liver enzyme, the same situation like with DILI case that suggested mixed type of damage with dominant hepatocellular injury after exclusion of other potential etiology, and hepatoprotective therapy. Patient had normalization of aminotransferase levels after 4 weeks. 3 months later, when we performed the fibroscan liver elastography, that showed the grade 2 of steatosis and 0 grade of fibrosis. On this slide and in this table, also we can see the review of literature where noted the cases of ashwagandha liver injury and the types of liver injury. First, 3 cases are from Iceland, thanks to Professor Björnsson, who wrote about that. And also 2 patients had mixed type. 1 patient had a cholestatic type of a liver injury. 2 types were from American, I think, literature review. In future collaboration, I would like to say that unfortunately, because of COVID pandemic situation, we cannot see each other and talk in real about the DILI and our society. So I decided to create an acronym, a new term about the DILI-nisation, that's the virtualization of the DILI network. So the main focus of future collaboration will be to analyze the different mechanisms for triggering DILI in various underlying disease and also in different hospitals. I told you that majority of patients in my hospital have been alcoholic liver damage, and in Palermo the situation is different, so it will be very interesting to discuss which potentially triggers were more important than others to suffering DILI in patient. So also the future collaboration will be focused on cooperation and sharing the knowledge and experience between the clinicians of different specialties, not only gastroenterologists and hepatologists, just and other, for example, endocrinologists, internists, and other. Now, next part of the slide, next slide, that's the short-time scientific mission invitation, where I can and want to say that here is the picture of my university clinical center where I work. So I would like to call young PhD students, young colleagues to come here in Banja Luka to our faculty, to our clinical center, to obtain clinical practice, to learn and to see how we do with the patients. And at the end, before I say thank you to you, I would like to show you one paper. When I arrived to Palermo on the first meeting with Professor Licata, she told me that during my short-term scientific mission, during 5 weeks, I should try to write something about DILI, and we wrote a paper about drug-induced liver injury and non-alcoholic fatty liver disease. So the paper was published after that, and that's one of the very important things of productive cooperation between Professor Licata, University of Palermo, and me from the clinical center of Banja Luka. So in the end, I would like to say thank you to everyone who listened to this presentation. Especially thank you to Professor Maria Isabel and also to Professor Javier Cubero, who recognized my ambition to work more and more every day, and my ambition to do something new to introduce about Dili in my hospital, to introduce about Dili to young colleagues, students, and others. And also thank you to Professor Anna Licata for everything we did together and everything I think we will do in the future. Thank you once again.
Well, Goran, thank you very much for your very nice words and for your presentation, and you are correctly explain how a clinical scientific mission should work, and we also thanks for your invitation of other people in your university clinical center. I think that the time you spent in Palermo very useful, because also we have another part of the cost in Banja Luka, because he start working as all of us work, and so the mission of the cost action, I think, is now growing up with the dissemination of everything that we every day learn to improve this cost. And I would ask if someone has some question for Goran about the clinical case.
I would like to congratulate Goran for this inspiring presentation, because indeed it underlines how important are short-term scientific missions to get more knowledge on drug-induced liver injury, to think about drug-induced liver injury diagnosis of exclusion, and also to start scientific collaborations that I'm sure are indeed very fruitful, thanks to Professor Anna Licata. This collaboration is already in a publication, so congratulations to you. Regarding the cases that you have presented, it's interesting that you always focus on the elastography. It's something that we don't know. It is a very interesting approach, because we usually do not have information about steatosis, steatopatitis, and liver fibrosis, like liver fibrosis in those patients that suffer a Dili episode, and once they have evolved or normalized. Do you follow the patient and do also another elastography? Because when you are in the acute episode, you may have some kind of interference, no? But do you repeat the analysis once the patient has normalized?
Sorry, for a moment. So in these cases, I presented that was the case. Were the cases for the clinical practice last year and this year. So we don't have any data about the status of the liver before the liver damage. So we don't know what happens before. In acute phases of the liver damage, it's contraindicated to perform the liver stiffness or fibroscan. So we did it few months after the normalization of the liver enzymes or second checkup. And my idea is to perform again also not only the transaminase levels, but also to perform a lipid status and other parameters, and liver elastography after 6 months after that control examination, just to make differences and to compare what is going to happen next.
May I say something?
Perfect. That will be very interesting, Laura.
Usually depends which patients you are analyzing, because for example, we are a tertiary clinical center in which many people are already studied for the steatosis. So we know for the most of we know how is the liver. When the DILI occur, usually in the acute time, we never measure because fibroscan is usually very high, so we don't. And maybe at the normalization of transaminases, so after 4 weeks, and then after 12 weeks, we usually follow the measure, and again at 1 year. So we usually follow people with fibroscan for at least 1 year after normally from the acute episode. And we have a fibroscan in my court. I have fibroscan from 2007, and we have a lot of people. We already know we have the cap from the 4 year. We have a cap, so we cannot have a whole court measured with cap. So we have a small part of the court with cap, but we know for the most of court how was the fibroscan and the liver stiffness.
Can I ask a question?
Microphone.
I have I'm unmuted now. Goran, so thank you very much for your interest in DILI and a nice talk. I have a comment and a question. The comment is that I think you should try to publish a case report on ashwagandha. It's very strange that this appears when this has been used in Indian medicine for so long time. So there must be something with the preparation that is marketed in the West. So because when we published our data, there were a lot of skepticism about it. So you should try to publish it. Are you going to do that?
Not yet.
But try to do that.
Okay, thank you.
Is, I was just wondering, you said in order to save the liver, you said that that you should rather use prokinetic medication rather than PPIs.
I thought itoprid.
Say it again.
When I told you prokinetics, yes. I thought on itoprid, not domperidone, not metoclopramide, just itoprid. Yeah. In cases, because a lot, for example, in my country, it's very specific how the people have everyday activities and everyday habits. For example, me, I have one or half, and from 1 to 2 meals per day, for example.
But I mean, the PPIs, if they are I think the indication of the drug is the most important thing. So if it's a good indication, the cirrhosis, use it like any other drug. Esophagitis or short-term healing of ulcer, but of course it's overused, PPIs.
Absolutely.
But I think I've never prescribed a prokinetic to a cirrhotic patient because it's not marketed in Iceland. But you think it's important?
Yeah. Because of for example, lots of patients with liver cirrhosis, alcoholic liver cirrhosis, suffer from obstipation. Okay. So PPIs, it's okay for patients with varices, ulcers, gastritis, and other conditions. But if you have patients with any signs of gastritis, without gastroesophageal reflux disease,
Yes,
only with stomach problems such as obstipation, I think in that case it's better to use prokinetics than PPIs, because PPIs cause the changes in intestinal microbiota and
I was just wondering if the prokinetic is safe. Do you have any? Is there any data on that in cirrhosis?
not published yet.
No. Okay.
Goran, I agree with Einar, because prokinetics in cirrhosis, they can go patient to tachycardia.
Sorry. Yes, if you use, for example, domperidone. Domperidone is prokinetic, which is contraindicated in patients with prolonged QT interval. But we have in our clinical practice Itoprid, which don't have any action on heart rhythm. Don't cause
And on the
prolongation
encephalopathy, and encephalopathy, encephalopathy.
Okay.
Portal encephalopathy.
What? I don't understand your question. Can you repeat again, please?
What about hepatic encephalopathy?
And PPIs or and Itoprid?
No, prokinetics. They are dangerous.
Itoprid, for example, metoclopramide goes to hematoencephalic barrier, but Itoprid don't go past the hematoencephalic barrier. That's a different condition. You know?
I don't know if in Italy Itoprid is commercialized, it's marketed. I don't know.
Okay.
I don't know in Spain or in Iceland. I don't think so. Itoprid. Let me check.
I don't know about Itoprid, but certainly Fisapride, which was the standard prokinetic drug, was removed from the market because it could induce fatal heart arrhythmias and also modification, hydroelectrolytics alterations and interactions with other drugs at cytochrome P450 level, even in young people taking, for example, macrolide antibiotic. So that's why it was, after many dear doctor letters trying to acknowledge and to make physicians aware of those potential dangers or safety concerns, it has to be finally removed from the market.
We in Italy have, I'm sorry, Maribel.
No, it's just to underscore the relevance of analyzing the risk-benefit profile of a drug in a particular indication also. Anna, you can say whatever you want.
Yes, I was saying that in Italy, Itoprid is marketed only with PPIs. This is an association, but I never used in cirrhotic patients, and I have I have seen a lot, really, because it's dangerous. I agree with you with the PPI that modify gut microbiota of the patients, and they are exposed much more to bacterial translocation or to damage from amoxicillin clavulanic, which is the most prescribed antimicrobials. But I'm not know about Itoprid because I never used.
Okay.
So we have some other question for Goran.
Oleg,
No?
would you like to say something with regard to early careers investigators? Or?
I think it was nice, so nothing to add. And good cooperation, and that was nice that Goran did this short scientific mission. This is a great opportunity from Post. Yeah, so hopefully to continue further. Good.
We hope.
So if, I would like to, Carlos, if you were so kind to add the new slide, I just wanted to take the opportunity that now that we are all together to announce, you might have received an announcement already about the training school on novel challenges in toxicology, advanced toxicology, that will take place in Lisboa, and who will be led by Joana Miranda. She could not attend this afternoon, otherwise she will have presented. If you capture the code, you can. It will take you to the program, the agenda, and everything. It is going to be an hybrid course, so you will be able to attend also online. And we have some grants that have already been given to the student, to the professors, or to the people who applied for them, and also to one of the speakers, that it will be covered all the expenses for traveling and stay by cost action. And it is really my great pleasure to announce the Nottingham meeting. I don't know if Guru, are you here?
Yes, yes.
Oh, perfect, Guru, much better. Thank you.
I can share. Okay, you have got put in a poster. I can share the program screen if you wanted. I can show the agenda. If somebody can unshare the screen, I can share it here.
Yes, sure. Carlos.
One second.
Yes.
Okay, Guru. Él quiere compartir, ¿no?
Yes.
Okay. Guru, now you can share your screen.
Thank you. Still comes up here an option. Okay, there we go. Share the screen. I think it's in here. Can you see now?
Yes, perfect. You can make it bigger.
Yeah.
Full screen.
Yeah. How do I make it bigger?
In the presentation at the bottom. Yeah, because it's Word. Yeah, okay.
Is that better?
Yes, much better. Yes.
Okay. Thanks for giving me an opportunity to announce this and share it with you. I hope most of you can make it. This was a meeting which we have been planning to have in March, April 2020. So we have postponed it 2-3 times, and we have come to an end of our chances. So we have to have it by the end of October. So we have decided to take a chance. I think I was not taking much chance. I was very confident that we'll be open, and we are open. I think there might be some requirement to travel, but we haven't had an announcement from UK government yet. But there is no restriction to have the meeting, or there is no restrictions to have the number limited to certain at all in any way. So we are hoping to have a hybrid meeting where we will invite as many as of you to attend. It's a combination of a workshop, our own meetings, which we have to have, working group and management board meeting, as well as a training school. So workshop is focused on new frontiers. The term looks like an oxymoron, but I'll explain why I called it that. It focuses on what I think is our contemporary and probably future topics. We have talks on checkpoint inhibitor-induced liver injury, which is funded now as an EASL registry. We'll talk about prescription event monitoring, which is a gap in this area, and computational modeling as well, which is underused in appropriate circumstances. We'll have really upcoming researchers working on stem cells, which incorporate to some degree host factors and in vitro systems. Two speakers, Tamir Rashid is a absolutely bright clinician scientist, and Takanube Takabe, another clinician scientist as well. We have also a training school which talks you through how to translate discovery to developing assay to make them near patient testing, and then how to turn in vitro into in vivo testing, how you use in vivo imaging to directly bypass all these animal models which don't work, in vitro models which don't work. And therapy, is there any chance drug-induced liver injury might have a therapy? So hopefully it's exciting enough for you to take a chance to come to UK, even if it means a bit extra hassles of probing your noses and throats and getting your passports printed with vaccines, whatever it takes. But there is no need to do a quarantine here when you come. And we are having most of the European countries on orange list, and I'm hoping that that gets probably watered down. So you might even have less restrictions. So hope to see you all.
Yes, we hope to join you in Nottingham. Yes.
Thank you.
And everybody is invited, because we will have a core group meeting and also a management committee meeting.